Chapter 16 in your Lewis text is fluid and electrolytes. If you look here at this diagram, it does show you that babies have quite a bit of water weight and older adults have less. This is why sometimes infants end up severely dehydrated if they get a GI bug, and little babies can actually die from dehydration. If you look at the slide here, we talk about intracellular and extracellular fluid. What is important that you would need to know here is that 1 liter of water weighs about 2.2 pounds, which is 1 kilogram. So if you think about, like, if you give a patient a couple of fluid boluses over, a day's time, that might make a big indicator. Anybody that's admitted to the hospital for any type of fluid and electrolyte disturbance should have daily weights. And body weight is an excellent indicator of overall fluid volume loss or gain. However, the body weight has to be accurate. So that means making sure that you know how to weigh the patients on the bed and that you're using the appropriate amounts of pillows, sheets, or whatever your floor requires so that the patient's weight from day to day is completely accurate. The next several slides here are a little bit of a review from anatomy. We're looking at electrolytes here, and the concentration of electrolytes is generally expressed in milliequivalents. You have intracellular and extracellular cations. I've left the definitions here for you for diffusion, facilitated diffusion, and active transport. This slide looks at covering osmosis and the osmotic pressure. And again, like I said, this is a review from anatomy, so I did leave this here in case anybody needs a refresher. The osmolality of the fluid surrounding cells can affect them. Isotonic means it's the same as the cell's interior. Hypotonic means that the solutes are less concentrated. And hypertonic means that the solutes are more concentrated. I thought this picture was especially helpful because some people do better with a visual. Shows you what a cell does in hypotonic solution versus isotonic, and then versus hypertonic. And the cell they're using here is a red blood cell. Also have the definitions of hydrostatic and oncotic pressure. It is important that you're able to understand why edema occurs. Edema is caused by a couple of different things. It's shift of the plasma to the interstitial fluid. It also is from the decrease in plasma oncotic pressure. Also, if you're looking at a patient when they have like very, very low protein levels, that can cause edema, things like that. So you always want to look at a patient's nutritional status and also what type of pathophysiology they have going on, such as cancer or things of that nature that can cause people to have a lot of fluid shifts, especially at end of life. First spacing is considered normal distribution. That means you do not have any edema. Second space is abnormal accumulation of interstitial fluid. This is just when you have normal edema that we would measure like in somebody's lower extremities, like their ankles, and this would be considered our 1, 2, 3, and 4 plus. Third spacing is when fluid is trapped, where it is difficult or impossible for it to move back into the blood vessels. This is more considered like your ascites in your abdomen, or if there's a huge amount of a fluid shift and it's not able to return back into the blood cells. And so I do think it makes a big difference if you're looking at, again, the pathophysiology of what is causing this. A patient that had like 3 plus or 2 plus edema in their lower extremities, if you elevate them routinely, you could help, kind of dispense some of that edema. We did have some edema models in the lab that I was going to have you take a look at, but since we're not at the lab, you could also try to go online and you could look to see if you could find any visuals of what edema looks like. There might be some good information out there. There is a chart in your book on table 16-2. It's looking at the normal fluid balance in adults. And the way that your body regulates your water balance has to do with the hypothalamic pituitary regulation as well as renal regulation. So you have receptors in your hypothalamus that sense fluid deficit or increase, and therefore then they would stimulate or suppress certain antidiuretic hormones. The renal regulation is very important because your kidneys are your primary organs for regulating fluid and electrolyte balance, and they adjust urine volume accordingly. The average adult makes about 1.5 liters of urine a day. And you can check the renal function pretty quickly in your patient by looking at their BUN, their creatinine, and their GFR, their glomerular filtration rate. You also have adrenal cortical regulation that helps with regulating water balance. You have glucocorticoids and mineral corticoids that are secreted by the adrenal cortex, help regulate water and electrolytes. Cortisol is considered your stress response, and this is going to increase your glucose level. So if you have an excessive stress response, you're going to have an elevated glucose level. The mineral corticoids, such as aldosterone, are going to enhance sodium retention and potassium excretion. We also have cardiac regulation as well as GI regulation, which can be very important and something to consider always in a hospitalized patient. There are a few things to consider when looking at the geriatric population. You have a structural change in the kidneys, which leads to a decreased ability to conserve water. There is a loss of subcutaneous tissue that leads to increased moisture loss. And we do have some changes that result in a decrease in renin and aldosterone and an increase in ADH and NAP. What you want to also look at with your patients, your elderly patients, is the decreased glomerular filtration rate. Normally, your GFR is greater than 60 in most patients, and a lot of adults, older adults, have a decreased GFR. So that is something to consider when looking at hydrating them and what fluid choices there. The extracellular fluid volume imbalances can occur for many reasons due to burns, illness, preps for different procedures, hypovolemia, such as if a patient's suffering from a GI disturbance, anything like that, dehydration if they're not taking in any fluids that they are like sometimes the elderly don't actually know to drink, so they're going to need to be prompted to drink, things of that nature. So if you look at who's at risk for dehydration, it's going to be people that have access limitations. So if somebody has to be provided with a drink, they're going to be more at risk for dehydration. This would include infants and babies and toddlers, as well as older people, anyone that is cognitively impaired. If we want to look at a patient that's suffering from a fluid volume deficit, what would they look like? So a patient with a fluid volume deficit could very easily have an altered mental state. So cognitively, they could be very, very confused. They might be restless. They could actually lead to the point of lethargy at some point if it was not treated. Also, with a fluid volume deficit, you're going to see a decrease in a pulse and you're going to see an increase in a heart rate. Those are pretty standard as what you would see. The patient could also suffer from like orthostatic hypotension when they stood up, things like that. You might also have a decreased skin turgor, a delayed capillary refill, a decreased urine output. And the pulse actually might feel almost like what we call thready. So like if you touch it, it feels like, yep, I felt it, but then where did it go? So it kind of disappears, or what we say sometimes is it obliterates with pressure. So you can feel it, but then when you try to push on it to count it, it kind of goes away. The patient might feel weak, they might be dizzy. They would also have some abnormal labs. So their BUN and creatinine could be elevated. their sodium could be elevated, and their hematocrit could be elevated. So those are things that you would look at if you were looking at lab work to identify a dehydrated patient. Fluid volume excess, hypervolemia, occurs for many reasons. It can have to do with abnormal shifts of fluid, giving the patient too much fluid. Some of the most common things that we would do is put a patient on fluid restriction, perhaps giving them some diuretics, and that would help to eliminate some of that fluid volume excess. What you might see in a patient that has fluid volume excess, you could see distended neck veins. They would have positive JVD, which is jugular venous distension. They might have a full bounding pulse, so their pulse would be bounding. They could have an elevated blood pressure. They could have weight gain. They could have fluid in their lungs, so they could be dyspneic and have crackles or rales in their lungs. You might notice some edema to their extremities. What you're going to notice with lab values is that their BUN is going to be decreased, their sodium level is going to be decreased, their hematocrit is going to be decreased. That is very important that you recognize that a patient that comes in that has fluid volume excess, those labs are not going to always be accurate if somebody's received too much fluid. There is a chart in your book on table 16-3 that you would definitely want to take a look at. It's looking at imbalances, deficits, and excesses, and that might be a good chart just if you want to make sure that you understand what's going on with these, the fluid volume excess and deficits. Things that you would want to look at in the implementation of nursing care would be daily weights, like we had already mentioned. Make sure they're accurate. Make sure that patients are weighed properly. The beds are zeroed with the correct amount of linen on there. An adequate I&O is essential. Laboratory findings are very important, as we had mentioned with the fluid volume excess and deficits, looking at that. Cardiovascular care, patients can have very low blood pressure, very high blood pressure, very low or high heart rates compared to fluid balance. So looking at all that is very important. Respiratory care is going to be essential if the patient has fluid volume excess, because they could have too much fluid in their lungs and they could be dyspneic and not being able to, breathe properly, and they could have crackles throughout their lungs. Patient safety is very, very important. Making sure that the patient, we're always going to be looking at neurologic status and how this is affected. Somebody that has fluid volume excess or fluid volume deficit could have some cognitive changes as well. So looking at safety is important. Skin care. You're going to be measuring turgor, which that is on the next slide, and you're going to be making sure that there is no skin breakdown. Sometimes when people have fluid volume deficits and excess, it can lead to impaired skin integrity. This slide demonstrates the assessment of skin turgor. So when you pinch the skin, it should return nicely into back down into normal shape. And then if you look at C here, it remains elevated a little bit, and that would be a sign of dehydration. Giving intravenous fluids is very important when a patient is hospitalized. You want to carefully monitor the rate of infusion. The infusion order is listed in the EMAR, so that's one of the things that you should be checking first thing in the morning in clinical, is to see what the IV should be running at and what the solution is. You want to try to maintain adequate oral intake if the patient is able to drink, and you do want to make sure that the patients that are having trouble with dexterity and able to, not able to get a drink for themselves or take a sip, that somebody is there to be able to assist them. Many times patients in a nursing home end up dehydrated just due to access, like they're not able to get themselves a drink. I'm going to have you take a look at this question here. It says, in a patient with prolonged vomiting, the nurse monitors for fluid volume deficit because vomiting results in. So take a second and look at your 4 choices here. The correct answer here would be A, fluid movement from the cells into the interstitial space in the blood vessels. A volume deficit occurs when there is a loss of both sodium and water. Next, we're going to start to talk about some specific electrolytes. This slide talks about sodium, and sodium plays a very major role in extracellular fluid volume and concentration, transmitting nerve impulses, muscle contractility, and regulating acid-base balance. Again, sodium is one of the values that you are going to need to know. We are going with a value of 135 to 145. The kidney is the primary regulator of sodium, and sodium routinely leaves the body through urine, sweat, or feces. Hypernatremia can occur with inadequate water intake, excess water loss, or sodium gain. It can cause a cellular dehydration. Your primary protection to this is thirst, so as somebody gets older, they might not have that protective mechanism. The clinical manifestations initially should be thirst in most patients. You will see mental status changes that could range from drowsiness to restlessness to confusion to lethargy or seizures. And this is something that you're really going to have to link with anybody that has an altered sodium level, whether it's hyper or hyponatremia. You're going to have to look at cognition. You want to do a good neuro assessment, as well as you want to look and monitor for seizures. Seizures are known if somebody has a sodium imbalance. Also, you might see some dry mucous membranes here. The person could have significant weakness. There are some causes and sodium imbalances, table 16-4, that you could want to take a look at. Another cause other than water deprivation here could be diabetes insipidus, renal failure, and Cushing's disease. So the treatment depends on what the underlying cause is. We'd want to make sure that we weigh the patient every day, and we would put them on a sodium restrictive diet, and also make sure that no IV fluid had sodium in it. Hyponatremia usually results from loss of sodium-containing fluids, like if somebody had a GI disturbance, vomiting, diarrhea, things of that nature, or it could also occur from water excess. Like I had said in the previous slide, what you're looking for is a good neuro assessment in anybody with an altered sodium level. So they could have just some irritability, some difficulty concentrating, or there could be more significant confusions, seizures, coma, things of that nature. If the cause is water excess, what you're going to do is you're going to do a significant fluid restriction. Also, you could look at giving some loop diuretics. Severe symptoms we might actually treat with hypertonic 3% normal saline. This used to be commonplace, but we don't seem to see that as much anymore. It's just one of those things that we used to do it all the time, but it just doesn't seem as the typical standard of care anymore. Also, make sure that you're looking for significant signs of weakness and fatigue in these patients. If the cause is abnormal fluid loss, then what you'd want to do is replace fluids with isotonic sodium-containing solutions. You would encourage oral intake. You would withhold diuretics if they were ordered for those, and you would consider drugs that block the vasopressin, the antidiuretic hormone. Vaprisol is a medication that is routinely given IV, and Samsca is usually given PO. Many of the patients that are suffering from water excess would be sometimes prisoners, people in behavioral health units. They tend to drink a lot of water, and they are trying to create this disturbance of having hyponatremia so they can be sent to a regular hospital. So that is something that you monitor for. If people have behavioral health issues, you'd want to monitor water access. So if somebody does have hyponatremia from water access, you're going to monitor their fluid restriction and really make sure that they are not able to have access to continuing to consume water. If it's from a fluid loss, if hyponatremia resulted from a fluid loss, you would going to want to, like we said, withhold the diuretics, replace the sodium solution. Also take a look at sodium containing foods. Things that are high in sodium would be such as cheese, some soups, processed meats, canned vegetables, things of that nature. This question is asking about a nurse that's administering 3% saline solution IV to a patient with severe hyponatremia. It is most important for the nurse to observe for what? So take a second and look at your choices here. The correct answer here is C, shortness of breath and increased respiratory rate. The 3% saline solution is hypertonic. And if anything is hypertonic, you always have that ability that it's going to pull more fluid into the vascular system. So therefore, the patient could end up with pulmonary edema, and they could have some difficulty breathing. They could also end up with hypertension. So those are things that we look for assessing respiratory status and blood pressure in somebody who's receiving hypertonic fluids. Potassium is a very important electrolyte. It is used for resting membrane potential of nerve and muscle cells, so it's very important in the maintenance of cardiac rhythms and acid-base balance, cellular growth. Some of the sources here are protein-rich foods, fruits and vegetables, salt substitutes. Also stored blood is very, very important that if you are going to give packed red blood cells to a patient, that you realize that it does contain potassium and that you would always know what the patient's potassium is prior to administration of that. It is regulated by the kidneys. You want to look at recognizing the skeletal muscle and realizing that muscle strength, it could be related to a patient with an altered potassium level. So that's very, very important if you had to link something. Also the cardiac rhythms. Many patients have dysrhythmias that have cardiac imbalances, or I'm sorry, potassium imbalances. There's a chart, table 16.5, that looks at hypo and hyperkalemia. Hyperkalemia is usually caused by renal deficiencies. Patients that are on dialysis would tend to have a hyperkalemia. And there also is if somebody had a massive intake of potassium, however, that's pretty rare. So the most common cause of a hyperkalemic patient is renal failure. It could also be caused if you had a patient that was taking potassium-sparing diuretics, sometimes a crushing trauma, too much packed red blood cells like we said before, if there was some type of adrenal insufficiency, those things. But for the most part, it has to do with renal impairment and renal failure. So the manifestations that you're going to see in a patient that has a high potassium level are dysrhythmias. We're going to have them on a monitor. You're going to be able to identify that. They could be fatigued. They could have some slight confusion. However, the confusion is nothing compared to what it is for the patient with the altered sodium level. You could also have some muscle cramps, but if you look at the third bullet here under the manifestations, it's weak or paralyzed skeletal muscles. This is very, very important. You are going to have to assess muscle weakness in these patients. So if you had to identify two manifestations that you're worried about or that you were going to link to a potassium level, it would be dysrhythmias and the muscle strength. Patients could also experience some abdominal cramping or diarrhea that have a high potassium level. If your patient does have hyperkalemia, the first thing you're going to do is stop any forms of oral or parenteral potassium intake. And you're going to look at increasing potassium excretion through diuretics. If it's super high, you might have to implement dialysis, or if you had a renal impaired patient. The other medications that we have here are Kayexalate and Patiromer. Patiromer is the generic name, and that actually binds itself to the potassium in the digestive tract and is eliminated through stools. Kayexalate, same type of thing here that you're going to have to do. It's going to eliminate the extra potassium through having the patient have stools. The Kayexalate or the hepatomer is not going to be that quick though, because you obviously have to give so many doses so that the patient would have stools to excrete this. If a patient had a very high potassium level and they were like in ICU, sometimes we use the insulin, IV insulin, along with dextrose, sodium bicarb, or even calcium gluconate that you could give to this patient. And what happens is that actually forces the potassium back into the cell. So you'd have to give D5 because you're giving insulin to a patient, and then you would also give sodium bicarb, and then we used to give calcium gluconate with that, so you'd either give sodium bicarb or calcium gluconate along with insulin and D5. And these are all given IV, and that would actually force the potassium back into the cell. The other thing that you want to make sure that you're doing here is that you're using continuous EKG monitoring. In a couple slides, you're going to see some strips, and we'll be able to identify clearly how evident this is on an EKG monitor. So just know that if the patient has a high potassium level, that you have to consider renal dialysis if it's that high. And otherwise, you're going to probably start with some diuretics and some of these other medications that we mentioned. If their potassium level is super, super high, you are going to probably have to use the IV forms versus the oral medications, which would allow the potassium to be eliminated in the stool. Hypokalemia, or a low potassium level, is often caused by losses in the GI tract. And so sometimes, if somebody had a GI disturbance, they were vomiting, had diarrhea, those types of things. Other potential causes could be diabetic ketoacidosis. It could also be like laxative abuse, things like that, people with eating disorders. The manifestations here, the cardiac are most serious. Again, you're going to be looking for dysrhythmias in these patients, and you'll see that on the next slide. The other things that you could be looking at here are weakness of the respiratory muscles, weakness of the legs, skeletal muscles. So if you think about this, remember when we said with potassium, the things that you're looking at dysrhythmias and you're looking at muscle strength. But here you have a weakness of the respiratory muscle. So can the patient breathe effectively would be very, very concerning for us to look at. You could also have decreased GI motility and hyperglycemia. You'd want to also look at bowel sounds. Does this patient have any abdominal distension? Do they have constipation due to the decreased GI motility? Now you will cover EKG rhythms in the cardiac portion of this course. However, the first picture here shows what a normal EKG rhythm strip looks like with a QRS waveform. The second strip identifies hypokalemia, which shows that you have an ST depression. And so you can actually see by looking at that does look a little bit different. It's not as significant though as the third strip with the hyperkalemia. And if you look at that very tall peaked T wave there, it is evident. So somebody that routinely reads a monitor would be able to identify hypo or hyperkalemia on a monitor strip. This is not something I need you to know for the test, but I do think that you do need to recognize it can cause dysrhythmias. And I just left them here so you could see how evident that they were. So how you would treat hypokalemia is probably with either oral potassium supplements or intravenous potassium supplements. Oral supplements would be given if the patient had a slight decrease in a potassium level. If their potassium level was super, super low or there was an issue, you'd probably want to administer IV. The third bullet here says to never give potassium via IV push or as a bolus. It's really not even available anymore. What would happen is it would come from the pharmacy pre-mixed if you had to give a patient IV potassium. So you'd want to probably highlight that fourth bullet here that says should not exceed 10 milliequivalents per hour, and that the fifth one says use an infusion pump. These are two things that are very, very specific to IV potassium administration. You are not allowed to go over 10 milliequivalents an hour, and you must use an infusion pump. So these things are just rules that you must follow. So for example, if a patient needed 40 milliequivalents of potassium IV, Each bag you'd get 4 different bags. It would come with 10 milliequivalents per 100 mLs, and you'd have to hang one bag at a time for 4 hours. Each bag would go in over an hour. Potassium also can sting, so sometimes it is hard for the patients to tolerate. It seems to burn a little bit when it's administered IV, so sometimes giving that through a central line is better. Even if you had a central line, the maximum amount you could give per hour is 10 milliequivalents. Calcium is essential for the formation of teeth and bone, blood clotting, transmission of nerve impulses, myocardial contractions, and muscle contractions. You do need to know that information there. You also need to recognize that it is obtained from dietary intake and that you need vitamin D in order to absorb. I have listed here as the levels 8.6 to 10.2. That should be on your lab sheet, and that is something that you do need to know. Calcium balance is controlled by the parathyroid hormone and calcitonin. The parathyroid hormone increases bone reabsorption, GI absorption, and renal tubular reabsorption of calcium. Calcitonin increases calcium deposition into the bone, increases renal calcium excretion, and decreases GI absorption. Hypercalcemia is the high level of the serum calcium. It is caused by hyperparathyroidism in most, 2/3 of the cases at least, and it could be also caused by cancer, and usually that is breast or kidney cancer. The manifestations here would be some fatigue, lethargy, weakness, confusion, dysrhythmias. You could also see hallucinations, seizures, coma, polyuria and dehydration, bone pain, fractures, and nephrolithiasis. I do have a table 16-8 in your book on hypo and hypercalcemia. For a patient with hypercalcemia, nursing interventions would be providing this patient on a low calcium diet. You'd also want to limit vitamin D, and then increase weight-bearing activity, increase fluid intake, looking at about 3,000 to 4,000 a day. Perhaps even some loop diuretics might be used. Hydration with isotonic saline solution. The biphosphonates is the gold standard, which means that's what people should be doing. And zoledronic acid, which is called Reclast, is a medication that could be used. Calcitonin would increase renal calcium excretion. Hypocalcemia, it can be caused by the decreased production of parathyroid hormone, multiple blood transfusions, or increased calcium loss. Could also be due to a decreased calcium intake, a vitamin D deficiency, pancreatitis, some chronic laxative abuse, maybe some diarrhea. Different types of things like that could also cause, like if you see somebody that's severely dehydrated or has had a significant GI issue, you might see some lower calcemia levels as well. The manifestations here are you're going to be looking at Trousseau and Chastich sign, and also looking for a stridor that could happen, dysphagia. They could also have dysrhythmias here. This patient could complain of numbness and tingling around the mouth or in the extremities. This first test here, A, is Chastich sign. So that means as you would stroke the side of the cheek, what you would see is you would see a contraction of the facial muscle there. If you look at B and C, what happens is when you inflate a blood pressure cuff on a patient's arm, that you would see the fingers, the spasming of the fingers in that situation that you can see there. And that would be called a Trousseau sign. For hypocalcemia, what you'd want to do is you'd want to treat the cause if you can identify that. Calcium and vitamin D supplements would be recommended. You could also give IV calcium gluconate IV, and that might be able to help as well. Treat pain and anxiety to prevent hyperventilation and induced respiratory alkalosis. And that would be also rebreathing into a paper bag if somebody is very, very anxious. That might help there. Phosphate is essential to the function of muscles, red blood cells, and the nervous system. It's important in the acid-base system. Serum levels of phosphate are controlled by the parathyroid hormone. Phosphate is required for adequate renal functioning, and it has a reciprocal relationship with calcium, which means that if one goes up, the other one goes down. We have phosphate listed as 2.5 to 4.5. You have a table in your book, table 16-15, that's looking at hypo and hyperphosphatemia. A patient's going to have a low or a hypophosphatemia level, usually with alcohol withdrawal, malnutrition, diabetic ketoacidosis with respiratory alkalosis. And you might see some confusion, and you might see some respiratory difficulties in a patient with hypophosphatemia. Somebody that has hyperphosphatemia, you would see that probably in renal failure, and anybody that has any type of renal disturbances could end up with a high phosphate level. Magnesium is also very important. It is important when you're looking at the cardiac status of a patient. I have table 1610 in your book that is looking at the magnesium levels. A magnesium level is normally 1.3 to 2.1. It is required for DNA and protein synthesis. It helps blood glucose control. It can also help with blood pressure regulation. It is very, very important for cardiac function. And what you're going to have to do is, if a patient is having some dysrhythmias, you would want to monitor the magnesium level. It's something cardiologists draw all the time. There's a rhythm that is torsades de pointe, and that is actually a form of VFib, which is a rhythm that can be incompatible with life, and that the treatment for that would be to give IV magnesium. Anybody that has hypomagnesium, that patient would also be probably somebody that could be malnourished, malabsorption, ETOH, which is alcohol withdrawal, and if somebody had been given a lot of diuretics, you were going to probably definitely see some dysrhythmias with these patients if they're hypomagnesemia. Hyper or a high magnesium level would be sometimes due to renal failure, adrenal insufficiency, and things of that nature. We are going to now move on to talk about IV fluid and electrolyte replacement. So IV fluids are given when oral intake is not adequate, or if the patient can't take in oral intake for whatever reason, say there's a GI gastroenteritis, or the patient has an obstruction, or they're neurologically compromised, so unable to drink and swallow, those types of things. Fluids are categorized by tonicity level, and there is a chart in your book that is looking at all the different IV solutions. That's on table 16-8. Hypotonic IV fluids are usually can be given as some type of a maintenance fluid. You would want to look for monitors and changes in mentation. Can be used to, if a patient is hyperglycemic, sometimes given, routinely given with somebody who's diabetic ketoacidosis. The IV fluid that you need to put in this category that you might want to write off to the side is half normal saline, which is 0.45 normal saline. That is pretty much the only hypotonic solution that you would need to know. That is the main hypotonic solution that we use. It's 0.45 normal saline, half normal saline. Isotonic IV fluids would be considered lactated ringers, normal saline, and these are similar in osmolality to extracellular fluid, so there's no net loss or gain from these. It is important that you do recognize that LR and normal saline are considered your isotonic fluids. However, LR does contain sodium, potassium, chloride, calcium, and lactate. So those you would have to be considering if you were giving them to a patient if you didn't want to alter those levels in that patient. So lactated ringers contain sodium, potassium, chloride, calcium, and lactate, whereas normal saline is just normal saline, and they are both considered your isotonic fluids. Hypertonic IV fluids should be administered slowly to prevent fluid overload. When you are administering hypertonic fluids, you would want to frequently monitor the blood pressure, the lung sounds, serum sodium levels. Some examples of your hypertonic solutions would be D5.5 normal saline, 3% normal saline, D5 normal saline, and D10. So D5W is a little bit tricky because it is physiologically hypotonic. However, it becomes isotonic as quickly as the dextrose metabolizes very quickly. So this one's a little bit tricky. If you look at some tables in some books, it's listed as isotonic, and in some tables in some books, it's listed as hypotonic. So basically, I'm not going to get, particular with this with you like on a quiz or a test, but I just want you to recognize that it's technically isotonic because what happens is the D5 quickly metabolizes, and so then you're left with pretty much of an isotonic solution. It does provide some calories, and it also can prevent ketosis. So if somebody's been NPO for a long time, this is not a bad choice, especially if somebody is having trouble controlling their glucose levels because they are no longer eating. Normal saline is very important. We give this a lot. It's an isotonic solution. It is compatible with most medications. It is the only solution that you can use when you're administering blood. And it is the preferred solution if you are trying to get an immediate response. You have to give fluid boluses, things like that, and it has to be administered quickly. So normal saline is very important, and it is probably something that you will hang quite a bit in the hospital. Lactated ringer solution is also isotonic. It does contain sodium, potassium, chloride, calcium, and lactate, like we had said before. It is contraindicated with patients that have liver dysfunction, hyperkalemia, and severe hypovolemia. You also have to have a GFR or glomerular filtration rate of greater than 60. Usually in order to hang this solution. So if anybody has an impaired GFR and they needed an isotonic solution, you would have to hang normal saline. D5.5 normal saline is hypertonic. It is routinely given as a common maintenance fluid. You can also add potassium to this. It is helpful to replace fluid losses. So for example, sometimes you might have an order that's D5.5 with 20 of potassium chloride. Colloids actually pull additional fluid into the intravascular space. Types of colloids include albumin, fresh frozen plasma, blood, such as packed red blood cells. There's also semi-synthetic, such as dextran and starches. These include Hespan. Hespan can routinely be given sometimes as the patient's in the OR. They'll give this. It kind of sticks in the intravascular space a little bit longer. It does help with blood pressure. And as it pulls additional fluid into the intravascular space, it does help, maintain adequate blood pressure for these patients. So that concludes our IV lecture, and I will post some questions regarding IV fluids and electrolytes, different types of things like that.